All right, so let me ask you this, because this has been one of my doubt, or not doubts, something that I've wondered pretty much.
Hmm.
So at the beginning of the pandemic, when it was in China, right, when
Yep.
the news first break out, it wasn't in the United States yet. We saw people in China pretty much falling over suddenly, fainting,
Mhm.
seizing, and doing all these things. But once it got to the United States, it wasn't the same, I guess the same turnout.
Mhm.
Do you have any information on why that might have been, or
Mhm.
what the case might be there?
When the only constant in life is change, you need to be ready. This is the Man-Made Survival Show.
Hello everyone, my name is Jose Prado with Man-Made Survival. Thank you so much for coming back to the channel and watching this video. Today I have a very awesome interview for you. This is Dr. Tan that I have with me here today. And he is a doctor, a survival medicine instructor, a former infantry soldier, and an outdoorsman. And he is going to be talking about a lot of things today that is really going to be very interesting for everyone to pay attention and take notes, because getting a doctor's perspective on how a real crappy defense scenario will, turn out to be or unfold. That's why it's important for us to take notes and pay attention to the doctor and see what he has to say today. Welcome to the show, Dr. Tan. How you doing?
Thank you. Thank you so much. So again, my name is Dr. Tan with the Survival Doctors, and we have a ton of good content for you guys today. Namely, what do you do with limited resources in a shit hit the fan situation? And not only do you have limited resources, you're either affected by the cold, the heat, an explosion. So those situations, a lot of these skills you need to know cold. What we train in the military is we just go through drills in multiple different scenarios so that when we're in that situation, it's almost automatic, even if you have a concussion, even if you're hungry, cold, tired, that whole 9 yards. So if you'd like, I can go over kind of like the big view, what I would do just to conceptualize how to be in that situation, and then go into a little bit of clinical pearls for each point. What do
Yeah,
you think?
yeah, that's great. That sounds good. Before we go into that, I do want to mention to the audience that you can find Dr. Tan. You can go to his website. His website is www.survival.doctors.com/links. And you can find him on Instagram at survival.doctors. And he has great content. He has a lot of information on there that you would really benefit following him on there and getting his stuff, because it's really great. So go ahead and give us what you think would a real capacity defense scenario would be
Yeah.
like.
Yeah, so I think from a survival standpoint, you got to think about things that will kill you the fastest, right? That's kind of like your priorities of what you would prepare for from a knowledge standpoint and the skills you kind of need to anticipate. Because in the prepping community, it's not all about having the right equipment, the right setup, the right vehicles, but it's also having that skills, that hand-on knowledge. So, Jose, are you familiar with the survival rule of threes?
I am, but would you
Okay.
mind going through them just for the audience?
Yeah, so first thing you got to know for the survival rule of threes is they kind of break it down into 3 minutes, 3 hours, 3 days, 3 weeks, 3 months. So in regards to what can kill you in 3 minutes, it's not like a hard and fast rule. You're without this thing, you will immediately die. It's when things get like threatening. So for 3 minutes, the first one is oxygen. So in this specific context, where do you think about oxygenation in a practical prepping situation? It's either you're at high altitude or you're at a very low altitude, meaning submersion. So let's say if you're in a boat, a submarine, or you're diving and you're out of oxygen, you typically have 3 minutes before metabolically in your system things get really hazy and you can make very stupid decisions that cost you either a life or a body part. So that's 3 minutes. And I'll go over into detail on each one, but I'll just give you kind of like a broad overview.
All right.
Now, 3 hours is a normal thermia. A lot of people think about hypothermia. It's the first thing that comes to mind, being too cold. But at the other side of the spectrum, it's very important to know how to treat hyperthermia. And when it's typically taught from a survival standpoint, they really harp on shelter building. But if you don't know how to actually treat that situation when you're actually deranged, you might not even get to that point of shelter building. You might be so deranged because you didn't know how to treat it, or you didn't know how to save that family member's life. And really knowing those telltale signs of severe hypothermia and hyperthermia is super, super important. And the treatment algorithms for it as well. And even one step further, the treatment for hyperthermia and hypothermia differs on how severe it is. So knowing how to very quickly identify, hey, that's a severe case versus, hey, this is mild, let's prevent it from going into a severe case is super, super important. And then you have like your food and water. So water being first 3 days without water. So from my standpoint, how do you purify water? How do you get safe drinking water? What is actual filtration? A lot of misconceptions are around Instagram and social media on how to actually filter water and make it safe for drinking. So there's a lot of crude methods that don't actually prevent you from getting illness from that filtration system. So I can review some of that very briefly as well. And then food's a pretty interesting niche to know about. We have our MRE packs, but when that's gone and you're kind of like in that extended system down, you're getting a lot of attacks from all different angles and you just want to get out of there. How do you hunt? How do you trap? And that type of stuff. And I'll talk about it briefly. But for those of you who are interested in hunting and primitive skills, what we do with the Survival Doctors is we defer that expertise to our survivalist counterparts. So in the Survival Doctors, we're a team of doctors, first responders, and expert survivalists. So each of us contribute a little bit of knowledge to give you the best type of education. So right now we have Donnie Duss, who was a primitive survivalist on the Lone Show, where you only go out with 10 items and survive as long as you can. So a lot of our primitive skills on YouTube is taught by Donnie. And the last one is kind of an often misunderstood and underlooked component, because when we think about prepping, we do think about our stores, our resources, but after that 3 months mark, you really got to think about your mental endurance. So mental health is absolutely super important, because if you have all the gear, you have all the training, you have everything, but there's something that gets you, some kind of trigger, some kind of unanswered question, or some kind of relationship that you didn't get disclosure with, it's at that 3 month mark where that can really wreck you. It can kind of just take away your will to survive. And for well-trained people, whether that's military or otherwise, that's when things start to crack, you know? And that's when they lose hope and make really silly mistakes. So yeah, that's kind of like a broad type of overview from a medical standpoint. Is any of that kind of ringing some bells for you, Jose?
Oh, yeah, definitely. And the one that I'm really interested in is the last part that you said, because people tend to think, you know, in the prepper community at large, what I've ever experienced is that people seem to think that a real capacity defense scenario is only going to last a couple of weeks, maybe a month or two,
Oh, yeah.
but then things will go exactly back to normal, you know, to the things that they're used to. And like you're saying, if it's something that's going to last a lot longer, for example, Venezuela, you know, they've been going through their hyperinflation for 7-8 years now. Yeah. It's something that a lot of preppers in Venezuela never anticipated. So taking care of that issue now mentally, you know, with all your preps too, it's going to be a lot better off for everyone else.
Absolutely. Now is the best time to really put a lot of effort, a lot of energy, a lot of care into your own mental endurance and mental wellness. Because oftentimes people, even today, regular people like you and me, just don't feel like they don't have time for it, that they deserve the care sometimes, or that they feel like it's not worth it, feeling like it's some kind of disease that isn't worth mentioning, that I want to keep secret. And I know for me that was something that I struggled with not too long ago as well. I'm not sure how much you've looked into my account, but way back when, this was kind of in between my military and medical careers, I was actually homeless, and not because of finances or anything like that, just a lot of bad things happened at the same time. And for me, that was kind of like a trigger for like a severe depression. I just didn't feel worth a roof over my head. I didn't feel like I deserved having daily food. So I kind of went into a very deep depression and chose to be homeless because that for me was my safe zone. You know, like I said, in the military, they train you over and over and over again that a lot of people, you see a lot of homeless military people in the past or today actually, that are homeless not because they can't afford it. It's just almost a safe space for them. And for me, I was homeless for over 6 months, and it wasn't, I'm trained in Arctic warfare and survival, so my safe space is the cold. And I actually spent a winter in Michigan during a polar vortex. So that's -30 weather, 0 heating overnight, with like 2 or 3 feet of snow and sleeping inside my car. And I did that for about 6 months until at the end of it, I was like, you know, I'm ready. I'm ready to like take care of myself. And sometimes it has, you have to figure out what your points are. I'm not saying the way I did it is the best way to do it. It's just how I coped. Looking back as if I was a doctor treating that type of person, kind of the options are, you got therapy and you got medications. And a lot of people don't want to be on medications, including myself. I was on medications for maybe two or 3 months, and then it just wasn't for me. But what it allowed me to do is kind of transition from a point of despair, from not wanting to wake up every morning and being sad all the time, to a little bit better. So a lot of what comes with depression, anxiety, PTSD, mood disorder isn't just the mood itself. So when you think about depression, anxiety, it isn't just that. You know, there's a lot of things like eating, there's associated sleep disturbances, and motivation, energy. So the medications, I can promise you more times than not, doesn't eliminate your feelings of depression or anxiety immediately. And it's hard to say, hey, this is actually working for me if that doesn't happen, because that's your main complaint, right? That's the thing that's keeping you down. But from our standpoint, if you're in a dark place right now and you're not on medication, you're not talking to anyone, you don't have a good support system, I'm telling you, medication might be an option for you to get over a hump. And that's how I explain it to a lot of my patients who really feel like they're in a severely dark hole and they can't get out. I'm not saying you should be on medication for the rest of your life, but I want you to be able to kind of peek your head outside that hole and have the motivation to say like, hey, let's check out what's out there. And that's what happened to me. And that's what has happened to a lot of my patients, because not only do I combine therapy, medication, I also combine a big component of motivation. I love being their coach through this whole process because like I mentioned, it's something that I've personally been through, and it's something near and dear to my heart and to my family as well. So for medications, there's a bunch of different side effects. So it's really important that you talk to your doctor about which one might be best for you. But one thing that's often overlooked is therapy. You know, something very specific to survival is cognitive behavioral therapy. So it's kind of changing your outlook, especially when things aren't going the way you want. One of the best things, or one of the most valuable things I learned in the Army wasn't how to shoot, wasn't how to blow things up or how to survive. It was expectations, especially in the infantry. They would tell you to do something, you would wait a long time, things wouldn't go as right, and you were constantly being let down until the point it was almost like a joke. You know, it came to that point where it was almost an expectation that shit would hit the fan and we would just adapt accordingly. And I think that's the biggest thing for people in long-term type of situations, whether that's, hey, you want to be out there in the woods, or let's say your vehicle crashes and you're really stuck days out. Like, expectation's huge. And if you expect rescue, if you expect all these things and they don't happen when you want them to happen, that can break you. That can break you really fast. So cognitive behavioral therapy is kind of one way to change your mindset in a very professional way to kind of overcome that. And another really good tidbit for people wanting to improve their mental health and endurance, there's 2 kind of tips and hacks that I've used personally that really sharpens my mind in those situations. One is meditation, and 2 is meditation under duress. So Jose, have you heard of Wim Hof before, or some of the stuff he does?
No, I have not.
So meditation is kind of coming in its own science right now. And the cool thing about it is because we can train people to meditate and also at the same time image their brain. So it's called a functional MRI, and we get to see what lights up in their brain and what type of things activate and how does that relate to your personal wellness, but also resilience. So if I could tell you that if I wanted to, I could increase my adrenaline, increase my dopamine, have all these feel-good endorphins go inside me, and then be ready for a fight or ready for something really, really dangerous, then that'd be pretty cool if you can call on that like that.
Right.
And a lot of people who are very serious about meditation, who train very hard and do it, are able to call upon that thing. But a very cool thing about meditation under duress is that you have these two meditation styles, but you do it under, let's say, a very painful stimulus like cold. That's what Wim Hof does, or pain sensation. What I've typically practiced in the past, because I do train in the cold, is cold exposure. Now, this isn't something that you should do outside of like a professional guidance or training.
Mm-hmm.
Wim Hof is a person who sets multiple records for this and who has mastered this and who teaches it. He has like an online course, and I'm not sponsored by him by any means. It's just one person, one professional to another. He has helped my life, and he has changed the way I think about meditation. So for that type of meditation, specifically when looking at the research that was done on him and his students, is able to call on his autonomic nervous system. So these are things that we typically do not have access to. I'm sure you're familiar with rest and digest and fight and flight, those type of reactions, you know?
Right. Yeah.
And because he's able to control how his body's responding when he's in these extreme cold environments, he was able to control how much basically steroids is in his system. So what has happened, and this was pretty cool because this was done in my area at Wayne State University. What we did is, well, not myself, but what our colleagues did at Wayne State was they injected him with an E. coli toxin. E. coli is a very common bug that causes anything from UTIs to stomach problems. There's a lot of different versions of them. But they took the toxin and injected him with the toxin. And what that does, as soon as it's in your blood, by definition, that's bacteremia, bacteria or bacteria equivalents in the blood. And they kind of monitor his response. A lot of people like you and me without training would often get severe fevers, get myalgias all over the place, complain a bunch. And then that kind of puts you in a place where, hey, I'm vulnerable. I'm vulnerable right now because I feel like I'm going to die. Mm-hmm. The whole premise of this study was he said he could do it. So we tested him, and he was able to increase his kind of immune response, his innate immune response to kind of attack this and suppress a lot of these side effects of this bacteria toxin. But the big thing that was kind of a mini breakthrough, and he was able to replicate this in his students. So he taught the method to his students, and they were able to replicate it, not only subjectively saying, hey, I don't feel those muscle aches, or I don't feel hot or anything like that. We actually have lab markers, so inflammatory markers that tell us, hey, there are things that are changing inside your body and you're calling on to it, whether that's through your mind or through your meditation, just some magical way that he's doing it. So that's why I think that's such a powerful thing to just be aware of for a lot of your viewers, because meditation isn't some poo-poo science. Like we have actual evidence to support it now, and it's really coming into its own kind of field. And for those extended exposures and shit hit the fan situations, I think it's such a good tool to master now, because things can only get worse, right?
Right, and that's gonna help you keep your mind cool and keep your nerves cool, and not fall into the depression that you're talking about, especially if things start to go wrong for preppers and for citizens alike. And that is pretty cool. I never heard of that, and I appreciate it for letting me know. Yeah.
And one more tidbit: in the UK, they're having studies on cold exposure because it's becoming more common. And what they're finding is this is preliminary data, so this might change in the future. But what they're finding is actual genetic modifications that changes your fat content. So typically, we would have something called white fat. That's just your regular fat that you have as an adult. As kids, you have a storage of brown fat. And that protects the kids because they don't necessarily have the best sweat glands or thermal regulation. So when they get hot or cold, they get in trouble. Specifically when they get cold, they use that brown fat, and when they burn it, it generates heat. In these studies with people with prolonged cold exposure training, they actually saw genetic modification that your gene upregulates the production of brown fat, meaning that you have a bigger storage of brown fat that actually makes you feel warmer. So it kind of makes sense for people who run Everest in their shorts through this training. They have a proponent of brown fat. And it's not like we're saying a lot of fat people can automatically convert their fat into brown fat. The study actually mentioned people of regular BMI, so around anywhere from 20 to 25 BMI are actually people that respond better than massively obese people to that kind of switch, which is pretty interesting because you would think, hey, I have a lot of fat. Can I convert all of it to brown fat? And the answer is probably not.
Yeah, and even if you could, you don't have the years of training to be able to actually
Exactly.
change your own genetics on that aspect. And
Yeah.
I mean, that's really cool. And I appreciate you for sharing that with us. I do want to switch gears to a different conversation within this field, right? So some of the things that I concentrate when I talk about in my podcast and different things is that we're really close to a war right now. Okay.
Yeah.
And coming things out of China, Russia, United States. I mean, those are the three big countries that they could go to war potentially here in the next few weeks, next few months, years. We don't know when it is, but it's almost certain that it's going to happen. So in one of those scenarios that if we have an ICBM, actually detonate over the United States or in Canada or some other place, what do you recommend people have ready that, as far as training and gear is concerned, for them to actually survive if they were close to the epicenter or, if they did get third-degree burn from an ICBM blowing up or something like that? What do you recommend for them to have in their kits?
And can you confirm what kind of explosive is this? Is this kind of like a chemical, or is it just pure kind of explosive type of device?
Well, I would think more like nuclear.
Okay. So if you're thinking about nuclear and you're in the vicinity, there's a lot of complications. But if you're thinking about, hey, I'm in the vicinity, but I'm farther enough to not be associated with burns and more so radiation, either way, you're going to get radiation. You're going to kind of have to deal with the consequences. You're not going to have access to chemotherapy at that point unless you go to a country that was not affected. In that situation, you're kind of shell shocked, basically. Like, who in their right mind would start a nuclear war with the USA? So when that happens, it's kind of like, what's going to happen next? Is it kind of like the preemptive strike? Because when you're thinking from a military standpoint, for a lot of tactical attacks, it's kind of like a hammer and anvil, right? Whether that's on the ground where you're an infantry person and you want to conduct a raid, you have a lot of firepower at first and then a sweep, So when I'm thinking about this strike, is this person going to strike and then, hey, that's it, like, see what we did and wait for the US to retaliate? Or are they going to very strategically strike and then have some kind of massive
Invasion force
to kind of sweep that?
Yeah, I mean, that's pretty much what my thinking is, that if there is, just we're talking about possibilities. If there is a strike in the United States, there's possibilities that, there could be an infantry already in the southern border just ready to come through. And, there has been defectors from Russia who would actually have come out and say that they already have people in the United States just waiting for that day to where they just go to the cache of weapons and then they start, doing their mission.
Yeah.
So in
is it likely? Probably not, just because of the amount of intelligence and the amount of military spending the U.S. has. I don't anticipate someone would have the resources to do that. I think if they were to do something, it would continue to be along the basis of covert operations. Things like the World Trade Center, things like massive explosions, chemical warfare, that type of thing. I think it's going to be a lot more subtle because from an invasion or a foreign attack standpoint, I think they're going to get a lot bang for their buck. If they go head to head with the U.S., it's very unlikely that they would win, especially with the American allies, Canada being one of them just at the border. So I don't think that would be the case. But very basically, when you're in that situation, you're not necessarily going to stay in your house, I think is the general consensus for most. Just by sheer numbers, even if you have a bunker or something like that, if you're in a suburban area or in a city, there's just so much risk factors for secondary fire, for troops to come in, just like a lot of things that can go wrong. And if you are ever tagged as a prepper, whether you're doing a blog like yourself and someone knows that you live there, I think it's very easy for me to say like, hey, this is the list of all the people I should hit because I know they have resources, or just looking at someone's backyard and noticing some of the modifications that they have to their house, or that they go shooting or something like that. I think it's very fast for people to get desperate, and even if they're neighbors, people get dangerous. My personal preference is to be as far as possible from people until things simmer down, and have like a communication device to kind of know what's going on. So if that's kind of something in line with some of you people out there, then the basic skills you need to know is how to build a proper shelter, how to kind of purify your water, how to do proper communication. So what you need to set up your communications and what the ranges are. So radio frequencies, how to kind of scope out lands and navigate. All these very basic survival skills is something that you should be very familiar with. And a lot of people just read about it, but they never practice it. And I think that's the biggest mistake, because that's such a false sense of security. So when we practice and instruct our students, yes, we do have instructional videos, but what we focus on, especially for our courses, is practice. Right now, in this COVID pandemic, a lot of it is, hey, let's do a live where we're all in the field and learning a very specific skill. Let's say it's making fire in the rain, pouring rain. What do you have in your kit to make that happen? And can you have that fire lit the whole night? How do you pick out the trees? How do you make your tinder? How do you make that fire work in this extreme type of environment? And we do it in multiple different places, multiple different altitudes. It really ends on mastery of this, because knowing how to start a fire one way isn't enough, because there's just so many different ways to do it. And if that resource breaks, you lose that match or you lose that lighter, you don't have your fire steel with you, you literally just have your two hands. Are you confident that you would survive and take care of your family? A lot of people may say yes, but in actuality, if you test them, things might not turn out the way that they think. And I think that's what we're trying to bridge the gap with Survival Doctors. It's really from the medical standpoint and the survival standpoint, what are the two big elements of what you need to have that situation where, like, oh, things are going down right now. Let's go to a safe area. But in that safe area, I need to know how to be independent. And I need to have a family that knows how to be independent, because it's not just about you. It's about having a unit to go out with. I think that's what we focus on a lot. So I can kind of talk your ear off on all these individual skills, but for the most benefit, for especially the primitive skills, go to an expert like Donnie. You can go to my YouTube at survival.doctors and look at his series, because he goes into primitive trapping, primitive fishing, and also how to make these fires. And it's such an important skill. So just to give you kind of like an outlook on the type of gear that I would have is I like having at least 3 ways to light a fire. So I have matches, I have torches, I have my fire steel, but also what's almost as important as an ignition is a highly flammable ignition source, whether that's pine sap, Vaseline, and cotton swabs. Like, these are some things that you should have in your fire kit. So I have like a pouch about this big that I know if it's pouring rain or in the snow, I can make a fire that can sustain myself for the whole night, no problems. I can do it every single time. And that's what you need, both the kit for it and the skills for it. In addition to that, like if you're thinking about that attack coming in, the first thing that's gonna be in your mind is things that are gonna kill you right now. So the things that are gonna kill you right now, like you said, was that burn issue. So burns will kill you eventually, but the inhalation from all that stuff will kill you sooner rather than later. Because what happens when you get exposed to all these fine particulates is your airway can have what's called like a bronchospasm, and it just shuts, kind of like an allergy, you know? When that happens, it's very important to know how to resuscitate that person and give them proper oral care, because if they stop breathing, that again, that's your first rule of 3 minutes of oxygen. If they're out for 3 minutes, the likelihood of survival gets thinner and thinner by the minute.
Is that something that can be done not in a hospital setting? Can somebody do that? You know,
definitely. There's like preliminary versions of it. So if your face is blown up and everything like that, and you have no way to kind of put a tube down, then yeah, that person's likely going to die. But for that person who has minor trauma, can still breathe a little bit, it can be as simple as positioning the person in like a recovery position. I'm not sure if you're familiar with recovery positions, but if you guys Google recovery positions, it's basically on your side, and that helps the tongue kind of go to the side. And most issues with airway can be significantly improved by just positioning of the head. So whether that's just a little tilt forward or the tongue out of the way, that helps drastically. So having the medical skills and the knowledge to evaluate, hey, the tongue is kind of in the way. And some people, if they're out of it, they're breathing, but their tongue is in the way. Let's say very specifically for obese people, you can literally take their tongue, pull on it, and then use a safety pin and clip it to their lips so it's out of the way. And that will save their life from a breathing standpoint. Because yes, it will hurt, it might wake them up, but if their airway is closed for more than a few minutes, and this is a mass casualty, you're checking on different people, that person's gonna die.
Right.
Plain and simple. But the number one thing that will get you fastest is bleeding. So when you think about your ABCs, in these situations when there's a military combat component, you don't do your ABCs first. You actually do massive hemorrhage first. So we have the acronym in the military called MARCH. So M being massive hemorrhage, A being airway, R being respirations, are they breathing, C circulation, H hypothermia, and head injuries. So that's kind of like the algorithm you go on. So you don't need to worry about hypothermia and head injuries if you haven't addressed bleeding, because that patient's going to die before you even get to that. So I have a trauma kit over here. I can kind of go through some very basic stuff if you want, or if you have other topics, I'm free to talk about whatever.
Let me ask you this first and then show us, because one of the things that I did want to talk to you about was gunshot wounds.
Yeah.
I don't know if you're familiar with Kyle Rittenhouse, what happened in Wisconsin, that he shot a guy in the arm and it pretty much blew off his bicep. Do you hear about that?
So we're in Detroit, so it's not uncommon to have a lot of gunshot wounds. We've had people with missing half their face in the emergency department going to trauma surgery right soon after, and then there's always retaliation if it's related to a gang war. So we do see a fair share of traumas in Detroit. I did that as a medical student and rotated through there. But right now in the demographic that we use, it's mostly motor vehicle accidents. But either way, you have a high velocity impact, massively disrupting bone, skin, blood vessels. Mm-hmm. So at the end of the day, your job is to stop the bleed. And from that standpoint, things are pretty cut and clear. So for that situation, I didn't hear about the story, but if he had a bicep blown, what's over here is your brachial artery. So that's the thing that you feel your pulse. You can push over here and you can feel a pulse. Mm-hmm. So I imagine if you got shot in the bicep, that thing was severed. And when that thing is severed,
it was pretty much like this part right here. You
yeah.
can actually see his elbow right here.
Yeah.
And it got blown away. And my thing about it, when I did that podcast, when that happened, is that you have to know how to take care of that. Because if you're in a real crappy defense scenario and there's no doctors, there's no hospitals or anything like that, and that happens in your group, can you take care of it?
Absolutely. If it's down here, you still have a little bit of wiggle room. So you still have the axle of the armpit. So if it was elbow right over here, you still have about 4 inches above that to put a tourniquet. So the specific things for tourniquets is that the guidelines have changed since when people just, there's a lot of misconceptions with tourniquets, and a lot of people don't necessarily know what to use for an improvised tourniquet, how to use a tourniquet, and when to use a tourniquet.
Right.
So very simply, the first thing you should try is direct pressure, right? It's the thing that everyone has access to. You put pressure directly on the wound and you just hold it there. Whether that's bunched up clothes, you can literally take off your shirt, bundle it up, and just put pressure there. And if that doesn't work and it's bleeding through within like 2 or 3 minutes, then in your mind, when you're evaluating the situation, is it safe? Because in that situation, not only are you trying to save this person's life, if there's shit still going on behind you and there's active gunfire and stuff like that, you need to stop right there and get that person out, because either way, both of you will be casualties. Both of you will be rescue liabilities to the rest of your team. So as you're trying to save his life, if you're active fire and returning fire, that person, you're looking for enemies and all that type of stuff. But as you're doing this, you're always checking scene before, during, and after, because the scene always changes. A lot of people say scene safety, good, they go in, but it's not a recurrent active tasks. You really need to have that 180, 360 view, have someone look at your six, because in those situations, it's different. It's not a civilian rescuing someone from a car crash. You're in a very dangerous situation. So being mindful of that. But I can pop off a tourniquet right now and kind of go over some of the basics of that.
Yeah, if you can share as your kid, that'd be great. I appreciate it.
So I have 2 kits, one bigger one and one that is a little smaller that I can hook onto a hip belt. But just to give you an idea, your tourniquets should be kind of the most accessible thing. That's why I have 2 on the outside. You should be able to get it immediately. And specifically for COVID-related traumas or or traumas in COVID times, you want to make sure you have access to protection as well. So on the outside, I typically have some eye protection, if not a shield. This is the bare minimum, some eye protection. And also what I do is I put in like a mask over here, because you don't want that stuff in your mouth too. So I mask up because my safety is the most important. I could save many, many lives. A lot of you with the right training can save many, many lives. So taking you out would be the same thing as causing a lot of harm to a lot of different people. So that's step number 1. So I have my tourniquet over here. This is a CAT Gen 7 from North American Rescue. North American Rescue is the same supplier to the US military. So it's something that's been approved. There's more than 7 different tourniquets that you can use that's approved that are highly effective. And if you guys want that information, just give me a message, whether that's direct message on Instagram, and I can show you the direct article which they studied these tourniquets. And it's also an Instagram post on survival.doctors, that's plural. But this one's the CAT Gen 7. The reason why I like this is not only is it standard issue in the US military, is it's super simple. So the one thing you want to consider in your personal trauma kit is, hey, if you're the person getting hit, is this simple enough that your buddy can put this on you, or a civilian that's coming by can put this on you? Because if you make the mistake in putting it in a position where you can't reach and your biceps blown off on this side and you really can't reach it, then you're kind of shit out of luck unless someone comes there, finds it, you can communicate that it's there and that they know how to put it on. And this one's super simple. It has a 1 buckle over here, so it's fast. You don't have to loop it over. I keep it loaded already, and you want it to be facing towards your body, because if you're kind of wailing on it, you want it to be this way and not the other way. So the thing about this is it has to be tight when you put it on. So let's say we got blown up at the elbow, you get 4 fingers above. So it's very rough estimate. You can just be like that, and you're like, hey, that's about right. You crank it down as tight as it goes, and then there's Velcro. You Velcro it in, secure it, and then you want to twist it. And you're twisting it hard enough to stop the bleed. And this second part is the part that a lot of people forget. You also have to stop the pulse.
Oh, okay.
So that's something that's super important that a lot of people forget. So I'm just gonna put it here like this, just for a demonstration, because I'm not gonna block my blood flow for the next few minutes.
Yeah.
And then you secure it with this Velcro, you put the time, because when you're thinking about timing of tourniquets, you don't want to put it long enough that you're risking the limb, but also you're risking the complications after a prolonged tourniquet. So a lot of people argue, hey, put on a tourniquet, leave it as long as possible. But that's with the assumption that that person is being evacuated to the hospital. In this specific situation, when, let's say, the whole system's down and you might not even get to the hospital days on. Are you going to leave that tourniquet on for days? Hell no. You would increase their chances of death by doing that. And that's a big misconception, especially for a lot of infantrymen who don't have that in-depth medical training, because they're taught, put the tourniquet on, don't touch it unless the medic or the doc says so. But they don't have the knowledge on why that is or when to transition, because they don't know the repercussions of prolonged tourniquets. And I have a video on that on YouTube talking about it. And I'm going to have another YouTube video talking about the details and the research behind that as well.
All right. So go ahead.
Once you stop the pulse, you kind of mark the time, say like, hey, this is when the pulse was done, and then you're good to go. Besides that, you should definitely, if it's rebleeding, you don't want to kind of untighten it, tighten it. That causes something called reperfusion injury, and you're likely to cause not only systemic changes, so more chances of getting like things like heart attacks or arrhythmias, or systemic issues like kidney injury. You're also injuring the extremity itself, so higher risk of amputation. So if you're taking it off, you should have the right training. So the same training that we teach in our course and we talk about, that's the type of training that you need. You don't want to be fiddling around with it. If it's rebleeding, what you want to be doing is putting a tourniquet above the one you just put. And the same thing, you're stopping the bleed and you're stopping the pulse, because if you're actively moving the person out of the scene, things change. Another thing is, especially if you're putting it on the thighs, if you're bleeding out from multiple different areas, your whole volume of blood decreases, including the blood in your muscles. So things need to be checked every few minutes, because as that gross blood decreases, your muscles kind of decrease in size and it's going to get loose. I can guarantee you that it's going to get loose. So you need to recheck as well. So it's not a one and done type of deal.
So should that be on bare skin or can that be over clothing?
Bare skin is the best. There's kind of two algorithms. If you're on active fire, let's say there's a bombing going on and things are not safe, and you really just want to put the tourniquet, drag them to a safe place, you can put it over the clothing. But the best thing to do, let's say there's one bombing or like one action and you know like it's pretty quiet around you and the scene's safe, you want to be cutting to expose the wound and then putting that tourniquet there. If you're not able to cut, you go high and tight and move to a safe situation and then expose them and then adjust a tourniquet. That's why I like having two. So I adjust it to the appropriate area and then keep on reevaluating. High and tight is something that has changed in the past few years. It used to be the standard of care. We're transitioning it to 4 to 5 inches above the wound because we've seen it that it stops the bleed faster. An argument, a lot of people saying, hey, we're trying to save life and limb. But if the scene is relatively safe and you can expose it, you're saving life and limb by putting it 4 inches above because it stops the bleed faster. And that's what we want. We want the bleed stopped as soon as possible.
Okay.
This is very, especially the case if you're doing lower extremity bleeds, because think about the muscle you need to compress in your thigh versus below the knee. And that's a big misconception because you can still stop the bleed, stop the pulse below the knee. A lot of people think the bones will not allow the compartments to compress. So that's a misconception.
Okay. So how would we go about, taking care of a gunshot wound after we did that, you know?
So gunshot wounds, not necessarily a massive bleed. You can have a gunshot wound over here and it can be just a pressure dressing, right? So pressure dressing, things to look out for our viewers over here. One that I really like, two actually. One is called the Israeli bandage. It's a great pressure dressing. And like I said, the first thing you should do to all these bleeding victims is apply pressure. And if the Israeli bandage is able to kind of compress that wound enough for the bleeding to stop, it's not going over the bandage, you're good to go. So in that situation, gunshot wound, Israeli bandage or pressure and then a bandage on top of it, like an elastic type of bandage, you're fine. But if it's still pouring, bleeding, again, the whole name of the game is pressure, whether that's a tourniquet, whether that's a pressure dressing like an Israeli or an Olace bandage. That's something that I really like as well. It's kind of an Olace bandage. If you think about pressure points, right? If you look at, if I were to poke you really hard in your chest or put a knuckle in you, that would probably hurt more than if I were to push you with my palm, right? It's a whole pressure thing. So the Olace bandage has a little ball to it, a little cup that goes right over the wound, and it's kind of like putting a finger right where that wound is to stop the bleed. So that I really like that bandage as well, and it's huge and bulky. So there's a lot of stuff that you can kind of cut apart or use it in multiple different wounds. So I really like those two bandages. If that's not working, then you're thinking about things like how do I apply more pressure? And a lot of people say like, hey, quick clot, combat gauze, that type of thing. But looking at the studies between a quick clot and just regular packing, we don't see a huge amount of benefits or time to improvement. And the price differential, if you're trying to get the best bang for your buck, you can get a bunch of compression gauze from North American Rescue. And I can post links in my bio as well. But these gauzes are super compressed, vacuum sealed, and they just have a ton of length to it. And what you do is you ball it up, and let's see if I have any here. I don't, but like what you would do is you would kind of ball it up, and then you would shove it into the wound. So if your wound's like this, you ball it up, and then you keep on shoving it in there until it doesn't go anymore. So it's so compact that you literally can't shove anything in there, and then you put a pressure dressing on top of that, and that will stop the bleed more times than not. The scary thing is if you get a bleed that's under the clavicles or in the groin, that's very hard to save. I would say the chances are, if you were to prioritize things, that person is likely going to die.
Okay, yeah, because all this information is really important, because people don't think about, you know, what would really happen in a crap at the fan scenario, and not only that, but how to address it, how to take care of it, how to you know, actually do it, and all of this is great information. I really appreciate it.
No, I'm glad. So, any other questions? I'm super happy to kind of answer. A lot of this, from a medical standpoint, I think it's best to have a nice overview of things, because I could only do you justice if I were giving you a very detailed thing on each situation. I don't want people to kind of glaze over the information, because all these, every single component of what I've talked about so far can be life-saving. So you don't want to skip out on each of these details.
All right. Yeah, and I appreciate it. I do want to move things along to talk about COVID.
Yeah, cool.
You know, there's a lot of talk out there in the mainstream media, in the alternative media. There's so much information that no one knows, you know, what the heck to listen to anymore. Absolutely. Is it a hoax? Is it real? Is it super deadly? Is it, you know, less than flu? So you as a medical doctor, what are you seeing in the hospitals, and what should people really be doing?
Absolutely. So just to give your viewers some background, I'm a general practitioner resident. So I'm a resident physician working in Michigan, and I've worked on the inpatient side, so treating people in the hospitals with COVID, in the ICU setting where people are really sick with COVID, people dying from COVID, and also on the outpatient side as well. So the big question is COVID real? And what should I do to kind of reduce my risk of getting it? And what can I anticipate to happen if I do get it? So number one, yes, it is real. The test specifically looks for the virus. So we're looking at the viral genetic material. So we've been able to kind of confirm that it is a real virus. It's different from influenza. Influenza genetic material is completely different from coronavirus genetic material. Coronavirus isn't a new virus, but the strand that we're dealing with right now is. And what happens, just like how influenza has different type of outbreaks, like the swine flu and all that, so does coronavirus. So it's not the same thing as your common cold, even though the common cold most commonly is coronavirus. So this novel coronavirus is something that is different. And what really gets people sick is that not only is it a virus that causes all these respiratory illnesses, but your immune system. What is really, really important is how it affects you systemically. So what we have right now that put a lot of people on ventilation, whether that's just a mask or actual intubation, is something called acute respiratory distress from a cytokine storm. So your inflammation, your body's natural response to this is saying, hey, this is not natural. I'm going to send a bunch of my immune system fighters. And that, unfortunately, that immune system fighters come with a lot of swelling. It's kind of like if you bang your elbow or something like that, things get red, hot, and swollen. That swollen stuff, imagine just hitting your elbow, it gets pretty swollen. Imagine your whole lungs being swollen. Your lungs take your whole chest. And if that gets really swollen, you can't have good air exchange. You're basically drowning yourself. And that's just the lungs. A lot of people are concerned just with the breathing issue. But the crazy thing about COVID is the inflammation that happens from it also affects multiple different organs. I was there at the very outbreak of COVID in Michigan up until when it started to cool down. Right now, I'm not treating any COVID patients just because our numbers aren't astronomical at our hospital, and there's no need for extra people to go in to have dedicated units. But at that time, when we were admitting literally 200 people a day within our hospital system, which is composed of 4 to 5 hospitals, we were seeing a lot of people get really sick, a lot of people going to the ICU, and a lot of people dying. We actually had a team that was tasked to just pronounce people dead. Like, that has never been the case for us during our residency program. Yes, we have people who pass away, but to have a specific person who their job is to go around and help people pronounce people dead is something that we have not had before. And it's something that kind of speaks to the gravity of the situation, that people get really sick and people pass away. And we've had huge families. So brothers, sisters, uncles, moms, parents just all pass away within a span of a few months. And a lot of the issues is not only breathing issues, acute kidney injury, and also hypercoagulation. So your blood gets thicker, and what happens is the things can clot, whether that's in your heart, in your brain, you can get a stroke from it, or actually in your lungs as well. So we've had people with massive pulmonary embolisms, big clots in the lung, and that can kill you like that, because you're basically cutting off the oxygen supply to your lungs. And like I said, again, rule of threes, 3 minutes without oxygen, organs are the same thing, 3 minutes without oxygen in your lungs, and you're pretty set for it. And just to think about the time it takes for the nurse to notice that the pulse ox isn't working, they might think, hey, maybe it fell off, to go into the room. It wasn't uncommon for me to walk into the room and notice the patient was dead. And that's something that we typically, we do see occasionally, but something that was very common, or more common during these times. So very serious. Right now, our job is to prevent the spread of it, because as we saw previously, from a political standpoint, from an economic standpoint, this has literally put a halt into our system. As a healthcare provider, we weren't treating as many strokes or motor vehicle accidents or all these other things, because our hospital was converted to a COVID unit, or primarily COVID unit. So if that's the case, what happens to all these regular common injuries and stuff like that? People are scared to go to the hospital, so they're getting strokes and heart attacks at home, getting repercussions from that, whether that's death or loss of function. And we're getting people who spread the disease because they don't believe it's real. Mask wearing, a lot. I also have social media accounts that talk to these people who don't want to wear masks, and a lot of conversations that I've had is that it decreases oxygenation and increases carbon dioxide poisoning. But these aren't like paper bags or plastic bags over your mouth. There is an exchange. Oxygen is a very tiny molecule. And to say that it doesn't go through a paper thin mask, a surgical mask, is just absurd. And to say that that you're not able to tolerate it in your 1 hour grocery shopping thing, when we have surgeons who's been doing this for literally decades, we have to wear this during our surgeries to protect our patients. And that's what it was initially designed for, to protect other people. They noticed a lot of infections in surgeries because surgeons didn't have masks, and it was actually cultured as oral flora, oral bacteria into their surgical sites. So that's why they wore those masks, to prevent that spread, and primarily respiratory droplets. Because even if you're talking, every now and then, I'm sure you've caught yourself at one point or another spitting just a little bit. And that little bit of spit, if it gets into the right place or the wrong place, that can cause transmission of infection. So there's kind of two two things. We got to wear masks to prevent the spread. And also we have to social distance because if it's primarily droplets, you just got to stay away from that mist. Another misconception is that it's aerosolized or airborne. Now, there's a difference with the possibility of aerosolization and what's the most common mode of transmission. In the hospital, for myself and people working in the emergency department, surgeons, in those situations where people are coming in very severe states and they're having respiratory distress, they're on a lot of oxygen, and we're also pumping oxygen in there, causing like more pressure to kind of flush out that water in the lungs. In those situations where we're intubating, we're all up in their face, yes, there is a possibility, a good possibility for aerosolization because there's a lot of pressure that flicks all these droplets all over the place. But in the community, it's not as common. Maybe if you're in an enclosure that recirculates air, that makes more sense. But if it's just you outside and you're worried about getting it through the air because there's someone like 12 feet away from you, that's not a common or realistic way of transmission.
Okay. All right. So let me ask you this, because this has been one of my doubt, or not doubts, something that I've wondered pretty much. Mm-hmm. So at the beginning of the pandemic, when it was in China, right? When the news first broke out, it wasn't in the United States yet. We saw people in China pretty much falling over suddenly, fainting, seizing and doing all these things. But once it got to the United States, it wasn't the same, I guess the same turnout. Mm-hmm. Do you have any information on why that might have been, or, what the case might be there?
So for our viewers, I just want to be very accurate and very specific to what I'm an expert in. So I did zero healthcare, zero treatments of the people in China. So I can't say what was fact there, what their demographics or their numbers were people who had seizures or not. All I can say is what happened at my specific hospital. And seizures was not a commonality there. Is there differences between populations? Yeah, that's a possibility. But it's not something that I can specifically talk on because I'm not an expert in that comparison.
Oh, okay. That was just one of one of the observations I made, and I was wondering why that was happening.
Yeah.
So
and it's also televised through the media, and sometimes they like focusing on very dramatic things if they can capture. So that might be the case.
Yeah, because that scared the crap out of a lot of people, because you're seeing people in China just falling over, bleeding from their mouth, their nose, and stuff like that. Very dramatic stuff. So that scared a lot of people very quickly. Yeah. But
I think there's also some misconceptions on what they were televising. I think some of what was televised was previous pandemics from China. And some of those previous ones did have those coagulation issues where they were bleeding from orifices. But I don't think that was necessarily accurate to the COVID infection.
Oh, okay. So it was pretty much propaganda from China.
I can't speak to that just because I didn't see any of it. So I don't know if they were talking about COVID or they were just talking about China being a source of pandemics, because kind of the same situation in the US. If there was a disease that originated in the US that went elsewhere, how it's portrayed by different countries, I can't speak to that because I wasn't there and I wasn't treating those patients,
Yeah, right. All right. So on the conception of people when they say, I don't want to wear a mask because you're wearing a mask, so that should be good enough to protect people. Is that something that, they have, I don't know, the right conception of it, or should everyone be wearing a mask, whether, they want to or not, whatever?
So if I were to give you the ideal number, it would be 70%. That's typically what we need for herd immunity. So that's kind of the same idea for vaccines. So if 70% of the population vaccinates and are immunized, they can protect the rest of the 30%. And 30%, whether that's choice or because they're allergic to the vaccine or otherwise, they can receive protection from the bacteria, virus, or issue that's going on. It's kind of the same thing for COVID. If there's more than 30% of people not wearing masks, as you see, the U.S. is kind of the leader in how long this is affecting our communities. And it's not a surprise in the medical community to say, hey, we're the ones having the most complications slash duration of this pandemic. We're having these spikes that come back and forth because we have a divided nation in terms of what they want to do.
Especially since everything's political now.
Yep, everything's political, and a lot of people who have no expertise in the medical field are making advice. And the crazy thing about it is, I'm sure you know how fast social media works.
Oh yeah.
And to change beliefs is so much harder than initial education. So for me to say, hey, I want to evaluate this research study, really know what the biases are, and present that information a few days later, that gets lost in the kerfuffle of people who have no medical backgrounds posting something, taking one chart off of like the CDC and saying, hey, masks actually make you more sick. So that's number one, they don't know how to interpret the data, they cherry pick, and also they propagate this, and it just gets viral because people want to believe what they believe. And when that spreads, it's hard to say, hey, that person has no qualifications, they don't know what they're talking about. And it's very nice to see how organizations like the CDC, like the WHO, who are actually changing their social media standard protocols to respond to those, and to respond to those more quickly. There was like a Twitter feed talking about this one person who said masks make people more sick, when there was no control, mask without mask, for that study. And the organization who replied to that responded very directly, saying like, that's a misconception and this is why. So I think a lot of that needs to happen. And as healthcare providers, we're not social media people. We are like, this is very new for us. So to have more influencers in the medical field provide very excellent and accurate information is super important, because the rate of misinformation is so fast. It's exponentially fast.
So if people didn't want to involve the media, whether it was, right-wing media, left-wing media, whatever, where could they go to get actual factual information that is not, regurgitated pretty much by the media? Where could they actually go and say, okay, there's this study from this place, and this is true, not, not a political agenda or anything like that? Where could they go?
Absolutely. That's a great question, because number one, even if you have access to the research, the problem is sometimes it's a little complicated to interpret that research. So I would get zero information from the media. The only thing that I would grasp from the media is the name, the author, and the date of that research article. And I would look it up and actually read the whole article. If you don't understand it, it's very easy to ask a medical professional, whether that's your own physician, to say, hey, what do you think about this article? Or I'm coming to the visit because I have trouble breathing, or I have a bunch of risk factors. I have this article that I'm concerned about. Can you interpret it for me? Or what do you think about this? And we would happily do that for you. As like a network, like the WHO, CDC, I know during this past few months, they've had good reviews, bad reviews, mixed reviews, politicized views, but they're kind of the person who summarizes a lot of this information. I'm not saying that their information is perfect, but from information that is understandable, that's a good starting point. You can take that information and ask actual professionals who are qualified to give that information questions, whether that's your pulmonologist, your primary care doctor, or an actual researcher to interpret this. Because you saying like, looking at the graphs and stuff like that, and saying that, hey, these people who wore masks got sick, but in the study, everyone was wearing masks, so it doesn't really help, is a big thing. Now, myself and other social media influencers who are physicians, practicing physicians, are also open to that type of discussion. So the people who are really engaged, I'm not sure if you follow Dr. Mike on YouTube. Shout out to Dr. Mike, but he is a family medicine physician who does a lot of general practice out in New York. And the way he approaches things isn't that I want to be the first one out there. He actually looks at the information, validates it, and looks at the biases and kind of presents that information in a summarized, easy to understand way. And I think moving forward, a lot of physicians should be doing that as much as possible on their social media platform if they have a platform, because that's what we need right now.
Yeah, exactly. All right. So what are your thoughts on the doctor that came out and said, that hydroxychloroquine, pretty much was the answer, and, everything that went along with that. But what are your thoughts on what she said?
Yeah, so that group who didn't wear masks, who were really promoting hydroxychloroquine and azithromycin, what you got to understand is, hey, there was one study that said this might work, and a lot of people ran with it. In this age, it's very hard to say, hey, I have evidence that this works, and I have 100% confidence that it's going to save you or to improve your situation. They were coming from a standpoint saying, like, I am sure this works. I give it to all my patients because it works, and you should get it too. So that was kind of like their standpoint. And the tricky part was that this was along the lines of when the actual studies were proving the opposite, right? Mm-hmm. So we have evidence that this drug does not improve mortality rates. So it doesn't prevent people from dying at a significant amount of rate. And there are side effects to every medication, and it just doesn't work. And the other thing is, a very important distinction is what kind of like capacity are you treating COVID? Is it outpatient? Is it inpatient? Is it intensive care? Because intensive care and primary care is very, very different. So COVID, like I said, is from the family coronavirus. Coronavirus is the family of one of the most common colds. And everyone responds to viruses differently. And when you think about responding to the common cold, some people get sick for a few days, some people get sick for like a day and they're done, right? Same thing for influenza. Influenza kills people, but still people get over it or they get worse. Typically, if you're the type of person to get over it sooner rather than later, it doesn't matter what I'm going to give you, you're going to get better. Okay. So if they're coming in and say like, hey, I have a scratchy throat, I test you, you're COVID positive, and I give you some magical dust, you're going to get better in a few days if that was your trajectory. But if you're in the setting where you need oxygen and I need to intubate you, and I've actually given you these things because no one knows what works, and then we find out 2 months later that it made no difference, I would take that evidence way more than someone who says like, hey, you had a scratchy throat, I'll give you azithromycin Plaquenil, and you got better in a week, because you were supposed to get better in a week. You kind of see that difference? Okay. It's kind of the same thought process for giving antibiotics to the common cold. We don't do that because if it's a viral illness, it's going to get better in 10 to 14 days anyways. So if I give you like an azithromycin, which is an antibiotic, at day 7, when you're saying, oh, I'm still feeling pretty sick, you get the antibiotic, and when you roll over the weekend, you're going towards day 8, day 9, day 10, and you feel better. You're like, oh, it must have been the antibiotic. But that's just your natural progression of the disease, that 10 to 14 days. So I think that's what happened in that situation. And for them to promote that drug without addressing that is a red flag to a lot of physicians out there. Oh, okay. And I think that situation was appropriately kind of responded to by the medical community, saying that it's something that we do not endorse.
All right. So before we wrap it up, one of the big issues right now that is pretty much coming our way is the fact that, they're working really fast on this vaccine that's coming out. Yep. Should people trust it? Because when everything just started, a lot of people first found out for the first time that a vaccine takes about 18 months to go through all the trials and see everything and be safe to give it to people. Yeah. Not including all the other things like it changes DNA and stuff like that, but just, do you think people should trust it as it's coming out when they say it's ready, or should they have a reason to be concerned because, they went too fast on it?
So when you say it went too fast, there is a standard kind of protocol, they have to meet certain milestones to actually progress. So whether that's animal studies to human studies looking at side effects, human studies expanding it to see if it actually does its job, to seeing how it responds to a bigger size pool. These are all safety measures. So it's the same thing as, or very similar to saying, hey, this new drug, is it safe? Now, for any type of new substance, the safest bet is to kind of see what happens when a lot of people get it, right? That's kind of the point of the clinical trials, because they want to know every little side effects that's possible. And number two is that there's multiple people making vaccines. So I can't say vaccines in general because there's a bunch of different companies, different countries that are working on vaccines. So to say vaccines in general are dangerous or should be kind of like you should be on alert for would not be generalizable. Here in the US, there is pretty stringent criteria to make things safe. Now, if you were at a higher risk of getting COVID, it's kind of your personal decision. You want to weigh your risk and benefits. If you have diabetes, hypertension, obesity, COPD, smoking history, still smoking, and you, basically if you got it, you would be in the hospital because you typically go to the hospital for all these chronic conditions anyways when they do get worse, then it might be in your best interest to take that vaccine. But again, it's a personal choice. As a physician, I anticipate, especially for the healthcare field, that it's going to be mandatory. Same thing as influenza. Unless you're allergic to it, you got to be protecting your patients. So if we're getting it, then like it should be good enough for the majority of the other people. Is there going to be skepticism? Yes. But what's the biggest reaction that can happen? And I think this comes towards how vaccines work, is it is testing and priming your immune system to fight. Will you get sick from a vaccine? Yes, that's a possibility, but that's an expectation. I think the biggest misconception is that when you get a vaccine, you're just going to be immunized against it. You're going to be good to go. But the whole purpose of it is to sprinkle in some proteins or some markers that gets your immune system targeted, saying like, hey, that's a bad guy, I'm going to attack it. When it does attack it, again, it's this inflammation cascade. And that's the normal cascade that can happen and turn out to a myalgia, so pain in your muscles, and you feel really sick. You might be in bed for a few days, but that's not necessarily giving you coronavirus. It's giving your immune response a trial. Same thing as, like, let's say if you were to exercise or to practice soccer for a soccer game. When you're practicing, you're still sore. You still have a risk of getting a sprain or something like that. But you are more prepared to play that team if you know what their game plan is, what their strategies are, what they look like, and how well they fight, or how their tactics are. So that's what your immune system is. So to say that you don't want to get it because you're going to get sick from it is not the correct kind of mindset. The mindset would be you may get sick from it, but that's not the same thing as coronavirus. When you do get coronavirus, if you do, you would have a much better response to it because it's already primed, meaning that you'd less likely be hospitalized, and you'd less likely lose your life because of it. And that's what the vaccines are for, preventing hospitalization and loss of life. It's not to prevent you from feeling sick. So that's the big misconception.
So is there a place to look at the studies when now that running the trials where they can say, here's the actual information, and you make your choice whether you want to take it or not? Because when I took my dad to the hospital about a month ago, something like that, and I just happened to ask the nurse that was there if he was going to take the vaccine, and he said that he really wanted to see what the effects were 5 years out. But since they were making him take it, then he had no other choice, because otherwise he would lose his job.
Yep.
So should that 5-year thing would be something that people should wait for, or should just look at the studies, or if their employers pressuring them to take it, should they just take it? So
from an immune standpoint, what it does is it primes your immune system, right? So when you're thinking about long-term effects, I know that's a huge issue for a lot of people. specifically in the obstetric kind of field, people who are having babies, because there are live vaccines that you're not supposed to get when you're pregnant. That should not be the case, because they're live vaccines. They're actual components of the virus that can infect baby, and cause long-term effects to your baby, actual congenital changes. But to look at vaccines that cause that same amount of issues in adults is something that we don't commonly see. The typical reactions we get are fairly immediate or short-term. So allergic reaction is a very real one. So it's not only the viral components that get put in vaccines or markers that look like the virus. It's things that kind of suspend it, like the fluid that we put it in. And if people are allergic to that, then they get like a reaction fairly quickly, whether that they need an EpiPen now or whatnot. But looking at, let's say you get heart disease or diabetes or some kind of malformation from getting a vaccine is something that we typically is not heard of from an adult standpoint.
Okay.
Now, looking at whether it's safe in pregnancy, that would be a completely different thing, because I'm not sure where they are at with testing it within pregnancy. Now, that nurse's kind of mindset for waiting 5 years out is pretty conservative, but again, it's all comfort level. From a medication for medicines, typically that's what I would be more inclined to do that, because it's something that you're currently ingesting on a day-to-day basis. And sometimes for new medications, that's the case. They may have had 100,000, a few 100,000 people take their medications and their side effect profiles were documented. But after 10 years, there are some things that can reveal itself. In vaccines, it's kind of less of the case for those type of congenital or changes because of what it does. It's basically identifying proteins, and your immune system are identifying it. So it doesn't necessarily change your risk for diabetes or these issues that a lot of people are scared about. And I think a lot of people are scared about what it does to kids specifically, because there's been such a debate in this country about vaccines and how that changes kids' growth and development.
Right.
So I think for a pregnancy standpoint, I might want more data seeing how safe it is for pregnancy. If it was my wife and my child, I want to see that data before I would say, hey, take it. But if I was like you and me, adult male, and I didn't get an allergic reaction, yeah, just give it to me. And if I get a reaction, I have an EpiPen, that's fine, because EpiPen there, observation 4 to 6 hours, you're good to go. If it's just a little bit of a rash, you take a little bit of Benadryl. If you have a fever related to it, notice that that's the normal thing that's supposed to happen. You just take a little bit of Motrin and Tylenol and you're okay. So when it comes out and it's safety approved, I will be required to take it, and I will take it. And I have no problems or qualms taking it.
Okay. Well, yeah,
that's my personal decision. It might change for everyone, especially as new side effect profiles are released.
Yeah, I think what is making people more nervous than anything is the fact that the government wants to make it mandatory, you know, and since everything is politicized and stuff like that, then they're not really trusting it, you know, depending on who you ask.
Yeah.
First, you know, they're saying that the left wants everybody to take the vaccine, but now that Trump is in charge, nobody wants to take it now.
Yeah.
So, you know, it all depends, I guess, who you ask.
Yeah.
Before we close, I do want to mention, and I wanted to give some information about the course that you're launching. Can you talk about that and when it's going to be available and all those details?
Awesome. So I'm really excited about this course that I'm launching. It's everything that I've talked about in extreme detail, and the only difference, or the big difference, is that it's not just a course and you have a few videos. We very specifically give you the same strategies and tactics we use in the military to train doctors, first responders, and you'll be getting very similar training and drills to really master skills and knowledge. So a lot of what I talked about before, putting you through scenarios over and over again, and having a lot of engagement for live sessions, in person, that type of thing. So it's everything from A to Z. If you were to survive in this kind of end of the world situation or a very extreme situation where you have limited resources, everything around you is going to shit, and also you want to protect the people that you care about. So what do you need to know how to survive and to address life-threatening injuries in that situation? So we're going to go through in-depth on every single component. And not only that, we're going to bring in experts. So we're talking about physicians who only specialize in, let's say, altitude medicine, who work on Everest Base Camp, physicians who just do snake bites or are highly specialized in snake bites, who do desert medicine, space medicine, like you name it. We're going to have an expert series that are included for free in the course as well. And the one thing that if you're seeing this right now, you might want to email me at survival.doctors.com because at gmail.com, because when this goes live, we're anticipating to go live around Christmas time or in the new year. When this goes live, we're only going to offer this course to 300 people. And the reason why we're doing that is because we want to give you the most up-to-date and also the most extensive survival medical kit. And it kind of looks like this one. And this kit is jam-packed with equipment that will save life immediately. So all the life-threatening things that we've talked about, that's the type of kit that I'm going to put together for you. So we can only order 300 up front, and that's what we're going to do. So the first 300 people in will get that pre-sale. So this year, the course will be a pre-sale thing because, number one, I'm a full-time physician. I don't have a whole lot of time and resources to put in making these videos. So a lot of the courses is going to be live. And the reason why we're doing a pre-sale is to get the funding and support. It's kind of like a Kickstarter to really film out everything and to make physical resources for you. But if you are one of the 300, you'll physically get the survival medical kit delivered to your door. And in addition to that, the big benefit for doing the pre-sale is that we're going to have a lot of live sessions as well, which will not be the case when the actual course comes out next year. So the actual course is going to be 3 times more expensive and also will not include as many lives. So the benefit of getting it now would be the kit and a ton of lives. So that's one-on-one type of training where I'm on video with you, or if you're in Michigan, you can fly out to me. So we're definitely going to promote it locally in Michigan and Ontario, just because it's very easy for us to kind of spend a weekend practicing and showing these skills to our learners. So that's a little bit about our course. That link's going to be up on my main page at www.survival.doctors.com/links. That's plural. And I should be putting that link right now. You can kind of pre-register for the course if you're really interested and want to save your spot. I'll send you a direct message when that course is live.
Oh, that's awesome, man. I appreciate it. Do you ever think you're going to be doing classes in person or anything like that?
So in person, what we're doing as part of a membership, and this is kind of like a sneak peek, so keep it on the download for you and your viewers. Right. But for a sneak peek, the one cool thing about us that makes us completely different from any other prepper or survival or medical resource is the amount of experts we have in our network. So again, we have first responders, doctors who work in very dangerous situations, whether that's a combat role or in a search and rescue kind of capacity, but also survival experts too. And what we've been doing is we've been going on training expeditions with both parties. So whether that's myself, who trains in Arctic warfare and survival and in survival medicine, and then additionally we'll have someone with primitive survival, and we would go out to like the backcountry on an expedition and train these skills and teach these skills. So part of the group, this will be available to only our inner circle members who buy that course. And in addition to that, there will be giveaways and scholarships for this as well. Our purpose of this, like at the end of the day, I'm a physician, like me selling this course isn't going to change my day job. I love teaching. I love providing the best care to my patients. What I want to do is to really prepare people for the worst because I want my family to have this resource. I'm basically building this resource for my family. So when they're able to learn this, that they have the resource and the community to say like, hey, I know what to do and I know who's going to be my fire team partner. I know which community that I want in this situation. And that's what we're building with this. So if you can't afford it, don't feel bad about it, because we will also have scholarship applications as well. A good chunk of all the course prices goes into improving your educational resources, increasing the amount of giveaways we do, and also having these scholarships for people who may be in the underserved area who can't afford our course, but who really believe in it and who really believe that it's important. Because not only are we teaching you, we're teaching you to be so highly capable that you can instruct it to your family and to your friends. And that's what our end goal is, to have as many people competent and capable to save life and limb. So that's what we're aiming towards. So that course is going to pre-launch this December or January. And if you're already interested in it, the link for the pre-registration is already live. So if you go to that link that I mentioned, you can kind of pre-register, and I will send you a direct link when it's live, and then you will have that seat if you want to get it at that time.
That's awesome. That's awesome. Well, I appreciate your time today. It was very informational, and I had a lot of fun.
Yeah,
I really appreciate that you came and you accepted the invitation to come on the podcast. And I'm sure that my audience is going to be very thrilled to listen to all of this. We appreciate it.
No problem. Anytime, man.
All right. Well, with that, we're going to leave things here. And again, this is Dr. Tan. You can go to, hold on, let me pull it up.
That's okay.
It's www.survival.doctors.com/links. And you can get all the information that he talked about today. You can go to his social media page, get all the information that he has on there, because he's posting content regularly. So it would be great for you to go on there and sign up and, follow and all those things. So again, I want to thank the Dr. Tan, and I want to thank you for listening to this podcast. Please share with your friends and family, because this information is very important for everyone. So again, my name is Jose Prado, and remember, always ready.
The Man-Made Survival Show.